and chronic low back pain. But I should clarify that when I use that term throughout this talk, I'll be talking about really disabling chronic non-specific low back pain, but I'll probably just call it low back pain or chronic low back pain most of the time. Before we kick off, just like to thank Kim, Toby and Francisco for inviting me to give this talk. So when we look at the issue of chronic low back pain, it seems very clear that it's a complex problem. The field's certainly settled on the idea that there's multiple biological, psychological and social factors that contribute to the problem of low back pain. And what we've seen over the last 30 odd years is really this explosion of research which has identified an enormous number of biological factors, psychological factors and social factors which all show some association with low back pain, be it the transition from an acute to a chronic state, explaining the status of someone with a long-going back pain problem, or predicting future status of someone with a chronic low back pain problem. And then there literally are hundreds and hundreds of factors which have been identified as being related to clinical status in those varying ways. So as a clinician trying to make sense of the data available to us at the moment, it's an extraordinarily difficult proposition to try and make sense of what are the important potential targets for intervention in patients that we see, what are these factors are causing, what is on the causal pathway, or what are just coincidences that can be ignored. It's a really difficult exercise, a really difficult space to try and navigate as a clinician. Added to that is the interactive effects. So clearly there's biological factors are impacting on the pain experience and psychological factors are impacting on pain experience, as I've said, but these things also themselves interact with each other, and it's arguable that the impact that those interactions have on the pain experience is even greater. So we've got this unbelievably challenging environment, and trying to make sense of that is the real challenge for clinicians. So the patient that's sitting there in front of me, what are the factors that are empowering in this person that are giving rise to their particular pain experience, and how do those factors interact? And really the question that we've got to ask ourselves is, how does pain emerge out of this maelstrom of biological, psychological and social factors? One of the ways that we think is helpful to go about that process is, first of all, having a really clear understanding of what it is we're trying to explain. And fortunately, researchers have done a really good job of this over the years, of having a really good go at producing some very precise definitions of what pain is. And this is from Milton Cohen, paper from a couple of years ago, really worthwhile paper to read, a very considered discussion about the definition of pain. And what they've come up with, this idea of pain is a mutually recognisable somatic experience that reflects a person's apprehension of threat to their bodily or existential integrity. Certainly mirrors a definition from a number of years ago from Lorimer that described pain as the conscious correlate of the implicit perception of threat to the body tissues. And people often add to that, and that idea that protection is required. So we've got these really all-encompassing, quite precise and profound definitions of pain to help us understand what it is we're trying to explain. And what seems to emerge from those definitions is that we're definitely using information to make a judgment, and that judgment is that there's a threat to the body of some description. And that judgment of threat then is manifested as a conscious experience, and that's conscious experience we call pain. What we next need to be able to do, I think, is to try and understand, well, what are the mechanisms that underpin that process? What are the mechanisms at play when we go from information to perception? So we make that judgment and pain emerges. So how do we make that judgment? How do we filter and make sense of the information to decide that our body is under threat in need of protection? And this is the world of perceptual science. And in that space, what's recognised really is that the goal of perception is to try and recover the causes of sensory input. We're bombarded with internal and external sensory experiences, and perception is about recovering what is it gave rise to that sensory input. And what seems clear is that the experience that you have, the conscious experience that you have, the perception, the percept that's generated, is not a direct readout of sensory data. We've talked about that in the pain field for a long time, and it's certainly been something apparent in the broader perceptual field for a long period of time. So, if you can change the taste of red wine by colouring it white, you can make chips feel more crunchy by simultaneously listening to a crunch sound in your ears. We bring together multiple sensory streams to give rise to an ultimate perceptual experience. So we're very clear again with that in pain that other factors other than nociceptive information can augment a pain experience. We can make something more painful by accompanying it with other threatening information, and we can make a pain experience less dramatic by accompanying it with more reassuring information. And we also know that our thoughts and feelings and beliefs and the context that we're in influence the eventual perceptual experience. So the same sensory stream for someone in a different mood state. So if you induce a bit of sadness in somebody, then the same sensory stream that might have given rise to a moderate pain experience will give rise to a greater pain experience because of a change in feelings that that person has. Also, the beliefs that they have or the thoughts they have about the meaning of pain, their level of catastrophization, their level of fear, and these sorts of things, again, can change the ultimate percept, the ultimate experience that they have for a given amount of sensory input. There's lots and lots and lots of support for these ideas that perception not being a direct readout of sensory data and perception being influenced by a whole host of factors in the pain world. So it's this idea that pain is best modelled as a percept, and the way that percepts emerge is by an inferential process. This idea that the conclusion that we come to, the actual experience that we have, is based on information that we already have. So again, it's not just recovering the causes of that sensory data simply by looking at the sensory data only. We arrive at that conclusion based on stored information already held within the system with which we filter that incoming data. So this idea that all people at all times for all modalities, all sensory inputs are being continuously cognitively modulated, most of the time at a subconscious level, but we're always modulating these sensory inputs, and it's that modulation which then gives rise to the ultimate experience, the ultimate percept. Okay, so when we're perceiving something, we're evaluating the incoming information against stored representations or held information. And the way the internet's full of examples to show you how that might happen. Here's one commonly seen one, so I apologise if you've already seen it, and for those who have will already be experiencing probably a constructed percept from looking at that picture. If you've not seen it before, your eyes have been bombarded with a sensory stream, a visual stream, and you're trying to make sense of that scene, and I imagine for most of you just see it as a random arrangement of black and white shapes. Okay, but if we then give the system some more knowledge, if we show you a picture, so that we provide you with more information, so the system has now more information, and then we re-expose you to the same sensory stream, hopefully most of you now construct a coherent percept of a frog from that same sensory input as before. So sensory input hasn't changed. What's changed is held information, and a different percept emerges because of the influence of that held information. So how does that happen? Basically, what we think is that it's a probabilistic process. It's the idea of a statistical account of perception. And the rules that govern this probabilistic exercise are the rules of inverse probability, the rules of Bayesian probability. So I'm sure you've heard this term about the idea of the Bayesian brain, a probability machine which is making predictions about the world constantly and testing those predictions. So this idea of combining information to arrive at a judgment which then emerges as our percept, that combining of information is a inherently probabilistic exercise. And the perceptions that are the ultimate outcome of that probabilistic integration of incoming information and held information are really an hypothesis regarding the causes of the sensory input, as we've said before, derived from both prior and the evidence that we're receiving are both represented as probability distributions with a mean value, so how much of a particular thing, and also the precision, or how sure we are of that particular value. So you'll often see these sorts of graphs used in the description of Bayesian perception. You can see here this idea of this would be our prior belief. So we've got a prior expectation of a particular state, in this case an estimate of threats. This is some data, a graph from a beautiful paper on this by Abby Tabor, looking at a statistical account of pain, and this is in reference to a sort of an explanation of placebo and nocebo data. So we've got a particular prior belief, and we have some the mean value of that, okay, and also the precision of that, so the distribution of that probability. And we have the same thing for the current sensory data. So if we just talk about what these things represent, this is an example where somebody has been exposed to a particular noxious stimulus, say electrical noxious stimulus on the arm, and we've got two conditions. On the left arm, let's say they've been told that they've got an anaesthetic cream on that arm, which protects them from noxious input, and on the other arm they've been told they've got a sensitizing cream, so capsaicin or something like that, which facilitates noxious input. Both, it's a placebo experiment, let's say both of them are exactly the same creams, but maybe they've been exposed to the anaesthetic cream and the sensitizing cream, but also they've got some experiences to draw on. So the scenario then would be on this arm, the person has a low expectation of threat from the sensory input that's about to arrive. They've been told that they've got an analgesic cream on. They've experienced that before, maybe, and know that it does make them feel less painful. They think that their body is more robust and protected against noxious input. So if we then deliver the sensory evidence to the system, that sensory evidence is combined with the prior expectations, and the percept is the posterior distribution. This is what they perceive, and it's a combination of both input and prior beliefs. On the other side, if this person thinks, well, my body is a bit more fragile and a bit more at risk than normal because I've got this sensitizing cream on, I've got an expectation of high threat from what's about to happen to me. It's the same sensory input in the two experiments, in the two different arms, very different prior expectations of what's about to happen, and you can see now that the posterior, the perceptual experience, is influenced by the prior expectations. So we look at the mean value and the precision of these estimates of both our expectation and sensory evidence, and their relative weighting is used to then optimize the posterior expectation, which is the eventual percept. So what's perceived by the brain is the brain's final estimate of the most likely cause of that sensory evidence, balanced on expectation and sensory evidence. Okay, so there's one thing just to touch on before we move off this slide, is the idea that it is a hypothesis. There's always uncertainty associated with that, and there might be something a little bit unique to pain under this Bayesian model, and that is that there is always some uncertainty about that, but we're probably conditioned to, if we are a bit uncertain, to favour danger over safety. If we think, well, is that a stick or is that a snake? It's probably better for survival to, when faced with uncertainty, to tip over to interpreting incoming sensory information as, if it's potentially dangerous, that will be a safer way to act. Okay, so this idea that perception, what emerges, gets sort of dragged between evidence and prediction, and that's dependent on the precision of those different estimates. So we can see a scenario where we have a very precise an imprecise prior, something that we're not really sure about, and precise data. And in that situation, our final percept gets dragged towards the data. So if you imagine listening on the radio to a song that you've never heard before, you're not too sure about what that song is. You've got some rules, you know the language. There are some rules about songs. There's usually some rhyming going on in there. They don't often have a wide range of topics that they cover, so you have some predictions about what's being sung about. But if you've never heard it before, the percept that you have is going to be quite strongly aligned to the income and sensory evidence. Okay, there might be, again, an occasional word that you miss, that you use a little bit of prior experiences to fill in the gap through there, but the perception, the end of this integration between held information and incoming information, favours incoming information when we're a bit unsure about what's going on out there. Okay. Alternatively, you can have a very precise prior and, let's say, a less precise incoming data. And in that scenario, then what you experience gets pulled up towards expectation. So if you're, again, listening to a song that you've heard lots and lots and lots of times and know very well, and maybe it's turned down very low, you can't really hear much going on, or it's in a bit of a crowded area where there's a lot of other things going on, you'll still have a very strong percept, a very strong experience of that auditory input, even though it's got low precision, you're not sure what's going on, because you've got strong prior experiences of that song, so you've heard it many times before. So what we see as the end product of this interaction between prior or held information and incoming information shifts around depending on the precisions of those different informations. You can understand the implications for this for pain if you've got a very precise prediction of pain with action, and you get some sensory input. Mightn't be very much noxious input, but if you've got a precise prediction of pain with action, then you get pulled up to that prior prediction. So you experience pain, which is much more reflective of your expectation rather than the sensory evidence. If I was doing the same task, say lifting a box, and I think I'm pretty strong and robust, and there's nothing wrong with my system, I'm all good nick, I've not got much of an expectation of pain, I get some sensory evidence associated with that, and my percept is more closely aligned with the sensory information rather than what I was predicting. Okay. Just to give a little bit of a back pain example, so this is a study we did a couple of years ago, really just reporting on one subject from that study. It was just a proof of concept study looking at a particular way of manipulating perception of the back. So we had a guy with low back pain. We got him to hold a box out in front of him, a particular weight that we knew was sensitive for him. Got him to hold it for a little while and to rate his pain experience. So here's someone has pain with lifting and carrying things. That's what he had experience with for a long time. We set him up with a scenario. We're going to get you to do something which is painful for you. So he would have had a prior prediction of pain. We get him to do the loaded task, hold the box in front of him. So there's some noxious input, so let's say entering the system. He then constructed a pain experience for that and reported that to be 7 out of 10. So he's both held information and expectation are combined to give rise to a pain experience in this guy. We then did a little bit of manipulation of the image of the back to make it look a bit more muscular, and we narrowed the waist and made the shoulders look wider. So and did some stuff to try and embody that illusion there. So he's now sitting there with different held information. Before he starts the task, he's looking at that going, well, actually my back looks more robust than it did before. It looks stronger than it did before. So this would be a scenario where he's maybe thinking of his expectation. It probably isn't going to hurt as much. My back's in better shape than it was before. Obviously the back itself hasn't changed, but the there's some information to drive his expectation to a less threatening one. So same task, same load, we would assume the same sort of noxious input, but this time with a different expectation of the consequences of the causes of that input, and therefore a different experience, so a lower perception of pain. So same input, different prior beliefs, if you like, and a different pain experience because of that. Okay. There's other things that are just worth chatting about in terms of this idea of Bayesian inference, and that is that the estimated value and the precision of both expectation and sensory evidence are constantly changing, where knowledge can update our priors. So if I'm sitting here in my room and I've got a model of the room which doesn't include a cat in it, if I put the cat outside myself about an hour ago, so I don't expect there to be a cat in my room. But if my daughter yells out, "Dad, I've just let the cat in," then I'm going to update my model of the world around me, that there is now a probability that a cat could emerge into my world. So I can use knowledge to update my priors. Obviously, in the terms of the pain world, you can go and see a clinician and they can give you some information about your back problem. They can say, look, for your back problem, lifting isn't a good idea. Or bending forward's probably a harmful thing. So you've thought, well, it was hurting when I bent forward and lifted. Wasn't sure whether it was a bad thing or not. I've now been told by a healthcare professional that it is a bad thing. So my model or my expectation now of pain on bending forward has been increased by that knowledge. I've updated the prior. We can also use action to influence the sensory streams. So if I see a movement out of the corner of my eye, I can turn my head so that sensory data, the photons, are now focused on the fovea of my eye. I can get better, more precise visual input. I've got a mild expectation of a cat in the room. I've had a sensory experience that could have been a cat. I've performed an action. I've turned my body towards where that movement was. I've got now more precise data that suggests cat, and now I've updated my model that there is a cat in the room because I've seen it. So I've used an action to influence the precision of that sensory stream that I had. And perception itself is the process of changing your prior. I had a prior before of a room with no cat in it. I've now gathered some data to support the idea that the cause of that sensory information, that movement in the corner of my eye, was a cat. And so now the model of my world is that there is a cat in my room. And so any other sensory information that I'm obtaining is going to be informed by that model of a cat in my room. So our perceptions become our priors. Okay. We can also change things by shifting our attention. I don't have a good cat example for you for that one, but if you think about you're listening to someone speak to you, and most of the time, if we're trying to recover the causes of that sensory stream, so there's some sound waves coming at you and exciting receptors in your ears, giving rise to a volley of action potentials, and you're trying to recover the causes of that volley of action potentials. You're trying to understand what the words are that person's given to you. You'll be focusing through your auditory stream to try and do that under normal circumstances. But if you're having that conversation in a pre-COVID world, in a very noisy environment where it's hard to pick up that auditory stream, you might shift your attention to your visual stream. You might be looking more closely at the movement of the lips and the facial expression, using that data stream to try and recover the causes of that sensory information. So we shift our attention around. So we have this real ongoing cycle of changing priors, of investigating senses, our sensation more by moving up and down, regulating the attentional information that we're getting from multiple streams. All these things are constantly interacting and constantly evolving, this interaction between perception, attention, and action. So if we just to summarize that a little bit, so what we're saying is that back pain arises when the brain's final estimate of the most likely cause of sensory evidence is an event that threatens bodily tissue. So again, this idea of integrating information, and our judgment is that the body is under threat. So the way we go about that is we build a model of the body based on prior information from the body, so information we're getting from the body, but also information about the body, what people have told us about the body, and other sources of information. We use that model that we've developed to predict the causes of ongoing sensory information from the body, and that's conditioned on the context in which the body finds itself. So that kind of summarizes that idea of our definitions of pain and how that's enacted through that Bayesian process. So what that means for ongoing pain, we think, is that the ongoing pain state will be when you have an internal model of a damaged and unhealthy self, and information from the back and the world around us that supports this supposition and is more available, and trustworthy than information that counters this. So how does that happen? How do we get ourselves into that situation? And that's what we really want to look at in this talk now, and that's how this is enacted. And what we're describing is this thing we've been talking about for a few years now, called the maladaptive perceptions model, which is a model which is sort of built around this understanding of pain being bodily threat, this understanding of pain as a Bayesian inference, an interaction between held and incoming information, and then tries to bring together what we know about the low back pain experience, what the data is telling us about the low back pain experience, to put in place a causative model of how these things interact to get us into this situation. Okay, so it all starts with some experience of low back pain. We do something to kick things off with that back pain experience, and that's not happening in isolation. People who are experiencing back pain are living in a society, existing in a particular context, particular family environment, in which it seems that most of the explanations of back pain emphasize damage. They talk about tissue injury and overload, and they certainly have this sense of permanence associated with them. To quote that beautiful line from the work of Ben Darlow, that backs are easy to hurt and hard to heal. So they're sensitive and fragile structures which can be injured or damaged easily, and once that's happened, they take a while to get going. This person's injured their back or hurt their back might, catch the train to work every morning and sit opposite a sign like this. So again, this is part of the societal explanations of back pain, demonstrating a very florid, red-coloured injury to the back and giving that kind of reassuring little byline there is damage or disc and there's no going back. So a beautiful embodiment of that idea of damage and injury, and fairly dramatic and florid damage and injury and permanence of the problem. So when we experience low back pain, it doesn't happen outside the context of the society we live in, and a lot of things happening in society do favour this idea of back pain being damage related and being hard to get rid of. The messaging that comes in from the manual handling world certainly emphasises that a lot as well. And that person living in this society is also experiencing things themselves. They'll be moving and experiencing pain when they move the back and they load the back, and they'll be generally experiencing lessening of pain when they rest the back and do less. So that's the kind of experience that fits in with the idea of something being broken and injured. So societal expectations are kind of being reinforced by the individual experiences of that person. They then might go and seek some care, and it could be online or it could be going to see a clinician, and not always, but often get exposed to diagnostic explanations that emphasise, again, tissue injury and insufficiency as the reasons for it. The waiting room might have couple of those things lying around, or pictures on the wall that are suggesting damage and fragility of the back. They might have been shown something like that again, which is kind of echoing what's happening up here of damage and injury to the spine as part of the reason. So the explanation for what's going on is often worded in terms of tissue injury and damage. They are maybe sent for an X-ray or a scan, and we know that the guidelines don't recommend that that's done for acute low back pain, though it still happens for a reasonable percentage of people. Many people with back pain themselves think that they should be, and think it's a good idea and necessary to understand their problem. And we know from the epidemiological evidence on imaging pain-free people that you're going to show something most of the time. If you take a scan of anybody, regardless of their clinical status, you're going to show things. So it's very likely that any imaging findings will show some findings that reinforce this idea of tissue damage and insufficiency of the spine. It's unlikely to be meaningless, but it still is in terms of the context of their problem, but it's quite toxic information for the system. And they might be given some treatments that emphasise unloading and protection as the solution. So rest or minimize movement, or don't do that movement, or move in this particular way. Things that, again, emphasize that idea that something's broken and damaged and therefore needs to be unloaded and protected. So those things are going on in lots of people early on in a low back pain episode, and you can understand how experiencing those things both sort of individually themselves within their exposure to the clinical world, but also from a societal perspective, that a cognitive model of a damaged, fragile and unhealthy self starts to emerge. So the held information starts to shift towards this idea of a pain expectant model. I'm going to start to predict or expect that things are going to hurt when I move because I'm damaged. That's what I've been told by the clinician, and that's how it feels to me, and that's what society says. It feels fragile, it feels unhealthy. It's this idea of our internal models starting to shift towards the model of an unhealthy self. And so the implications of that is that the back is appraised as being untrustworthy, and so a back that's not fit for function, and the back's viewed as being under threat and in need of protection. Not everybody transitions to a chronic state, though those experiences we've just talked about are common experiences, but not everyone also goes through those experiences. Some people get explanations of back pain that don't involve more catastrophic thinking. But there's a host of data on the factors that do contribute to chronicity. And when you look at those really common factors, they again fit very well into this idea of driving this cognitive model of a damaged, fragile and unhealthy self. So recurrence is something that crops up often in those models of being something that predicts transition to chronicity. And you can understand how that would enact under this kind of supposition. That if you've hurt your back once in 20 years, you wouldn't be thinking, oh, geez, my back's a write-off. It's in really bad shape. You might think, well, that's just something that's happened. I'm not too worried about that. If you've hurt your back 10 times in the last year, then you're going to start to develop different cognitive beliefs, different beliefs about your back. You're starting to think, well, it is, things aren't going well here. It really isn't behaving well. It's wearing out or whatever. If we look at pain intensity, again, a strong predictor of transition to chronicity. If it's a mild pain experience, the nociceptive barrage in the back isn't too much, let's say, then that's not the kind of data that's going to lead you to a supposition of a damaged and fragile and unhealthy self. You might sort of explain that away as being a normal ache or something that not to be too concerned about. But if that nociceptive barrage initially is of a strong nociceptive barrage, and you are experiencing high pain intensity, and it's tricky. I mean, I'm not saying that high pain intensity is always related to a high nociceptive barrage, but in that acute episode, it probably is in some way related to that. Then that's data that's more likely to change your model of a healthy self to an unhealthy self. And again, the data support that. And similarly with persistence, if the problem's been there for a day or two, you might think, oh, it'll be okay. I'm not, things aren't in too bad a way. Things aren't that damaged or broken. But if that persists for a week or 2 weeks or 3 weeks, then it starts to become a more likely interpretation that something is broken and damaged in there. And again, persistence is a very strong predictor of persistence. Psychological factors that have been shown to predict transition to chronicity also fit into this idea again of driving us towards a cognitive perception of a fragile and damaged back. Depression, this idea of hopelessness and low mood and nothing to live for, all drive this idea of it being unhealthy and damaged, hopelessness about future outcomes and what can be done for the problem. You think, well, this is never going to get better. There's something really wrong in there. These ideas obviously are manifestations of that idea of a broken and fragile self. And same with anxiety. So somatization and these sorts of things, particularly health-related anxiety, again, are going to contribute to interpreting sensory data as indicating something broken and damaged, leading to us developing this internally held model of a damaged and unhealthy self. Finally, comorbidities feature pretty strongly in the prediction of transition to chronicity in an acute pain state. So having multiple pain sites, self-rated and your general health is poor, having other disease states active. And again, you can understand how they, again, drive that idea of I'm in pretty bad shape here. I've got neck pain, I've got shoulder pain, and now my back's gone as well. That's, it's another one of those things that are going wrong with me. I'm falling apart, that sort of idea. So you can see very easily how comorbidities, which are reasonable predictors of chronicity, fit well into that idea of driving a cognitive model of an unhealthy self. So what we're ending up with is this idea of I'm starting to believe and think I've got these cognitive models of my body that's unfit and needs protecting. And so what that does is drives some particular outputs of the system. We start to afford more attentional resources to noxious information. So if we're thinking our backs, we've got this high perceived need to protect the back. And we're thinking that noxious information is something we need to look at more closely and think about more. And we decrease our focus on other sensory inputs. So we have this weighting towards noxious information and away from other sensory inputs. This idea of kind of hypervigilance, if you like. We also, not only do we attend to noxious information more, we also scrutinize that noxious information differently. If we think the body is broken and fragile, and that increases the threat value attached to that noxious information, again, maybe touching on that idea of catastrophization about the meaning of that sensory input. And we also move in different ways. We enact these movement strategies that limit spinal movement and co-contract and increase rigidity and decrease the movement repertoire. We become more rigid and inflexible and less variable in the way that we move. And we avoid movement. So we do less. And then when we do things, we do them in these more stereotypical, less varied ways and minimizing the amount of movement that's happening in the back. Some of these are being enacted by the person themselves making those decisions, but some of these things are a result of advice they've been given by clinicians. So what we're seeing is this shrinking of the movement repertoire of the person. They're doing less, and when they do stuff, they do it in more stereotypical, less varied ways. And those actions that are driven by that cognitive model of a fragile and unfit body are going to create changes in both the brain and the body. And we've got an enormous amount of data showing structural and functional changes in various areas of the central nervous system in people with low back pain, some biochemical disruptions, some morphological changes, and lots of representational, organizational, and changes in the way different areas connect with each other in the brain. A vast amount of data are now available suggesting that the central nervous system's function is greatly changed by the pain experience. And we're suggesting that particularly attentional processing, motor control, and sensory processing are part of that. Obviously, the body is going to be changed by these actions as well. We're going to unload the musculoskeletal system, and we're going to start deconditioning the musculoskeletal system. So the information that we're getting from the body is going to be changed by these actions. Obviously, we're shifting our attention to information from the body, and we're scrutinizing the information from the body differently, but we're also getting different information from the body by the actions that we're taking, and the musculoskeletal system is not being used as much, so it can decondition as well. So if we just look a little bit closer at all of those things, so we're thinking from an attentional perspective, what is then happening from those central nervous system changes, that noxious information is then able to more readily capture attention than non-noxious information. And we find it harder to disengage from noxious input. So you see in experiments like a dot probe task, when they expose back pain patients just to pictures of people doing provocative tasks for the back, that their fixation times on those provocative pictures are more than on neutral pictures, and different to what we see with low back pain patients. They're more attentive to noxious information, even though it's not involving them themselves. We also see this in data, and it's being strengthened recently by a couple of studies. There have been a few papers in the back pain world over the years, a bit more evidence in the neck pain world for this, but we see this idea of people becoming hypoaesthetic. They're hyperalgesic, so they're more sensitive to noxious input, as we'll see in the next slide, but they're demonstrating this hypoaesthesia, so less sensitive to non-noxious input. So our attention is being driven towards noxious input and less towards non-noxious input. Lots and lots of evidence that nociceptive processing is then disrupted in people with low back pain. We see facilitation of nociceptive input. We see in decreased inhibition, so enacted through blunted conditioned pain modulation response. We see greater local sensitization, but also remote sensitization throughout the body. We see this greater summation of pain, both locally and remotely, in people with low back pain. So here, if we stimulate the hand of people with low back pain, they're reporting more pain than healthy controls. You see less activation in some of the brain areas that are responsible for enacting inhibition of noxious information. So we've got this facilitatory increased efficiency of nociceptive networks and poor ability to inhibit noxious information. And from a sensory motor perspective, a number of things that are changing that sort of fit under this idea of body image or body perception. Evidence that we've got disruption of the brain-grounded sensory motor representations of the back, seen here in the motor cortex from Siobhan Chaubrun, this beautiful example of this smudging of the motor cortex that they've described. If you look at for the healthy person, this is the center of mass of the representation for the superficial back muscles, and for the deep muscles, if you lay those two on top of each other, you can see those nice discrete populations of neurons. If you lay these two maps on top of each other, you can see that overlap between two different muscle groups with very different anatomy and very different functions being represented by the same neuronal population. Similar findings here in the sensory cortex, where we see this the representation of the back in low back pain patients being shifted towards the area where the leg is normally represented in primary somatosensory cortex, again interpreted similarly to the motor cortex of suggesting this reorganization of the brain-grounded maps of the back, on this lack of delineation and demarcation in those representations, so a sort of smudging of those representations. Not only are those brain-grounded maps disrupted, the sensory streams that we use to update those maps, but also build higher level representations of the body, like our body schema and our body image, that also seems to be disrupted. We've got augmentation of sensory streams suggesting an unhealthy body, as I mentioned. We're attending to noxious information more, and we're getting much more efficient at the way in which noxious information is transmitted. So danger messages from the back are augmented. Information that's suggesting an unhealthy body is being augmented. And we're losing fidelity of the sensory streams that inform a healthy body image. And again, these are sensory streams that are used to formulate our body schema and our body image, where we are in space, where we are in relation to the world around us, how we go about planning and organising movement. So we're getting disruption of our body model, we're probably getting disruption of our body schema, and disruption of our body image. And the body itself is deconditioned. We've got decreased capacity and low tolerance of the musculoskeletal system. So the consequences of all that, so the end point is it's hard to know where to start. I think these things just meld into each other, particularly these two, and sort of self-interact. We've got a back which is more sensitive to noxious input from that increased nociceptive efficiency. We've got this scenario where noxious input is seen as more trustworthy and afforded more precision, therefore is given more weight in deciding what's going on in our back than non-noxious information. We've got a back that is less fit, it's deconditioned and less load tolerant, but also because of these central nervous system changes, it's got this disruption in the brain grounded maps and the fidelity of information that informs our body schema and our body image, that the back starts to feel foreign and peculiar and disconnected. When you ask people to draw pictures of the back, they draw these sorts of things that suggest a very, very disrupted body image, a very disconnected body. Questionnaire data supports that. Qualitative data supports that the back starts to feel different to the person. It feels less controlled. It feels less part of them. And so what's happening is that these internal cues that we have from our tissue and our representations of our back that give us our cues that the back is fit and healthy are eroded. Okay. We use our brain grounded maps and the non-noxious information from our back to plan movement, and very important for motor control of the back. So part of the apparatus that we use to plan and control movement is being degraded. So again, it's likely that some of the maladaptive loading that might be happening in back pain patients is enacted by these central nervous system changes. You can imagine that if this is the way that you perceive your back, then the motor control strategy that you use when you're moving and loading your back are going to be greatly influenced by that disrupted perception of the back. There's also this idea of a mismatch between predicted and actual feedback. When we perform a movement, we predict the feedback associated with that movement, and we monitor to see that there's a concordance between what's predicted and what actually happened. And if you're planning a movement based on the perception of the back like this, which is obviously not the reality, then what you expect might be different from what is actually happened. And it's thought that mismatch can give rise again to further feelings of foreignness and peculiarity and lack of control of the spine, that it doesn't feel part of you. It might be pain causing itself in some circumstances. The data's a bit unclear on that, but what seems a bit more clear that it does again reinforce this idea of foreignness and peculiarity. And we start to minimize the amount of movement that we do. We start to explore the movement landscape less because and minimize the opportunity to learn more about the back and about what's going on. There's also this idea that maybe we're disrupting homeostasis by this process. So it comes from some suggestions from the complex regional pain syndrome world, a condition characterized by fairly florid disruption in body image, and also the sort of autonomic dysregulation. And there's some experimental support from the idea if you disown a body part, then you shift homeostatic resources away from that body part. I don't think it's too big a stretch of the imagination to say that this person's probably not going to be expending homeostatic resources on this part of the body because they don't perceive it. And so it might be that part of decreased fitness of the back comes from deconditioning, but also part of it might be a downstream effect of these perceptual changes in the back. Okay, so what we're ending up with is that information from the body strengthens the internal model of a damaged, fragile and unhealthy self, and information that counters this is less available and less trustworthy, as we said at the start. And so what then happens is that this all leads to reinforcement of perception of a back that's unfit for function and in need of protection. And so that kind of summarises what we've just said, that a cognitive model of an unfit and unhealthy self emerges from the experiences that the person has in the early part of their low back pain episode, impacted upon by their interaction sometimes with the healthcare profession, but also features of the episode. It's the intensity of the pain, whether it's a recurring episode, how long it's lasting for, and some psychological features of that person, depressive symptomatology, pessimism and hopelessness and health-related anxiety, drive this idea of a back that's untrustworthy, not fit for function, and is under threat. We then change the way we attend to information, we change the way we move, we change the meaning of information from the back. This drives central nervous system changes and changes in the body, and we then get this interacting effect, which leads to, as I said, we've got information from the body that strengthens the internal model of a damaged, fragile, unhealthy self, and information that counters that is less available and trustworthy. So that then feeds back up into that cognitive model, and that's the cycle that we get caught in. Okay, so that's me done. Thanks very much for having a listen. We've also got some implications as far as treatment goes that then emerge from that, but that'll have to wait till next time. Thanks very much. See you later.